Well, welcome everybody to the 29th installment of the PhenoTips Speaker Series. I'm your host, Kira Deneen. My pronouns are she, her. And today we get to do probably my favorite webinar of the year, the PhenoTips Speaker Series. Sorry to everybody else, but super passionate about Pride Month. So this is, I believe, our third installment. I think we've been doing this 3 years because the show's been going for 4. So today we are talking about LGBTQIA plus affirming prenatal genetic counseling. And I was saying before we are live here that this is something that's very close to my heart, is being part of the queer community and also being a prenatal genetic counselor. So I get to check off 2 boxes there. So thank you everybody who is trickling in today. As I was saying, this is the 29th installment of the PhenoTips Speaker Series. We've been going for 4 years now. I think this month, exactly, we're celebrating 4 years. So it's been very exciting over the years to be able to connect with everybody internationally and live. We are truly live. This is not pre-recorded, which is really, really fun, and being able to just interact with everybody in that way. So what we're going to be doing today, for those that aren't familiar with our format, I do an interview with these 2 lovely people who I'm going to introduce in a moment. And we're going to take your Q&A, or take your Qs and give you As at the end. So as you think of questions, don't say, oh, well, you know what, I'll just pop them in at the end. While you're thinking of questions, while we're live here, for people that are watching live and not watching it later, please use that Q&A box in the Zoom at the bottom and submit your questions. We would really love to be able to have this be interactive and answer questions that you have. We really want to take this as an educational hour and be engaging in that way. So please, I'll remind you guys throughout, but submit your questions throughout. And I wanted to thank the sponsor of this series, PhenoTips. PhenoTips is a complete electronic health record integrated solution for medical genetics. So PhenoTips offers software and services that reflect the diversity of modern families and ease genetic professionals' workflow. We've all experienced different EMRs, EHRs, whichever term you feel more comfortable with, being students, working in different areas, and they're not designed for us in genetics. It's usually we have to find some kind of way to make it kind of work for us. So that's what's really nice about the PhenoTips Genomic Health Record, because it has tools like inclusive pedigree builders, which obviously super relevant to today's topic, because I really admire PhenoTips for continuously updating their tools to meet the latest standards for LGBTQIA plus representation. They're really at the forefront of this. And that's, why we've been able to do these webinars every year, where we're able to touch base on this and see what's new and keep people educated. I also got some insider information recently, and I'm going to share it because why not? PhenoTips update is coming later this month, and it's going to further improve the representation in pedigrees for the LGBTQIA plus community. And it's going to be aligned with all of the latest literature and standards. So I'm very excited to look at this. So again, insider info that I'm sharing with you guys live here. And other tools that PhenoTips has an automated pedigrees, human phenotype ontology capture, built-in cancer risk assessment. So it's just already in the platform there, and diagnostic insights. And as I said, these electronic health records elsewhere really aren't built for genetics. The people at PhenoTips are genetic professionals that have experienced this and said, hey, let's figure out the ways that work best for us as genetic professionals and provide that unified and seamless genetic workflow. So definitely make sure to check out PhenoTips there. So wanted to introduce myself before we get to our awesome panelists here. My name is Kira Deneen. I use pronouns she, her. I'm the host for the webinar. As I mentioned, I am in the queer community, and I host and produce some other podcasts. The main show is DNA Today, which is award-winning, and we're hitting our 300th episode over the summer. So look out for that. We've been producing episodes for 12 years. And my other hat that is relevant for this conversation is I'm a prenatal genetic counselor. So 2 days a week, I see patients in the telehealth setting, which is kind of newer for me. But anyway, that's about me. But more importantly, let's get to our guests today, our lovely panelists that are really going to bring this conversation to light. We have Rosalia Valentine, who is the genetic counselor at Boston Children's Hospital. I should say one of the genetic counselors at Boston Children's Hospital. She is an expert in pediatric neurogenetics and works with families of children with neurological disorders to help find genetic etiologies. We also have Chelsea Wagner joining us, who is the lead genetic counselor at Billion to One. And Chelsea has a lot of experience in prenatal. She served as the reproductive health expert for NSGC's media panel, also past co-chair of NSGC's prenatal special interest group, or SIGS, as we all say for short in genetics. So thank you both so much for coming on. I am really pumped to get into this conversation. And again, today we're talking about LGBTQIA plus affirming prenatal genetic counseling. So thank you both so much for joining.
I am so
Thank
excited. Thank you for having us.
And I figured we could kind of just start out with you both sharing what initially inspired you to specialize in genetic counseling, really advocating for LGBTQIA plus community members. Do either of you want to start out by just kind of sharing your background and kind of what led you to be kind of selected for this webinar?
I can go first.
Great.
So I actually applied to genetic counseling school with an essay about being queer and the research that I wanted to do surrounding the LGBTQ plus community. And so I talked about the lack of representation. I talked about the lack of research. I talked about the way that the genetic counseling world is not necessarily representative of the communities that they serve. And so from the very beginning, I knew that I wanted to do something that would help my community as well as assist the genetic counseling community.
Amazing.
And I had a little bit of a different route to becoming an ally for the LGBTQIA plus community. I have been a prenatal counselor for about 6 years, but in the past 3 or 4 years, you may have heard there has been some lack of abortion access and restrictions on reproductive healthcare and reproductive justice in general. And as I was working on those issues, it became really apparent that not only does that affect the entire reproductive health community, but in particular, it amplifies issues and challenges for this particular community. And so from there, I've been doing a lot of learning, a lot of researching, and a lot of finding out ways that I can continue to advocate as an ally for this community.
Amazing. Yeah, I think it's just so important for us to highlight it. And especially with Pride Month, right? So I love that, all month long, there's different types of, I would say, celebrations and ways that we're able to educate people. And I think it's important. We have so much to cover, but one area I kind of want to start with is how genetic counselors and other healthcare providers in the genetic space and in the prenatal space, kind of both of those, can create a psychologically safe and inclusive environment for people in the community during these prenatal genetic counseling sessions, because this is an area that can be heteronormative, and it can really kind of stride that way, which is difficult, where things are really set up for a cis straight woman. And so it can be really hard to transition to that, but it's so important to do that. Is there anything that comes to mind for the two of you of ways that genetic counselors can be more inclusive, as well as other healthcare providers in the prenatal genetic space?
I can take this. I worked in a in-person clinic for about 4 years. And so I think a lot of having a safe and inclusive environment is the way that things are set up, and that are things that I feel like we've heard about, but maybe haven't necessarily implemented in physical clinical spaces. So having name tags with your pronouns on them, having signs saying, this is a safe and inclusive environment, and really making our workflows different to suit the needs of all people instead of this is the way we've always done it. This is how facilities and bathrooms are always signed. You know, there are definitely things that you can do to make the physical space more inviting. And that would be sort of my suggestion for those in clinic. I myself do see telehealth patients. And so I think that is an area that maybe we can have some more ideas, some conversations about how do you make a telehealth appointment that's 30 minutes, safe and inclusive? How do you signal your pronouns? So I think telehealth has also added a whole other layer of things to consider when we are serving these patients.
Yeah, definitely. I think that's something that I've been adapting to. January this year, so 6 months ago, I switched. I still work at the same practice, but we adapted my role to be telehealth. So I was in person for 3.5 years. And now I'm like, okay, how am I transitioning things so that it can be that? And sometimes like just sharing your pronouns like as part of your name on whatever platform you're using, something like Doxy or a Zoom kind of equivalent HIPAA protected platform, things like that. But it's definitely different when we're switching, especially when most of us have experience in person. And you can have things on your desk like a flag or something like that, or wear a pin. Whereas like, on the screen, you may not have that. Rosalia, any other thoughts to add on to what Chelsea said?
Oh, I've got many.
Good.
So the first thing that I want to emphasize is that the LGBTQA plus community is not a homogenous group. And so anything we say today is not something that you can just slap on to any member of the community that you meet. And you will meet members of the community. Queer people make up at least 7.1% of the population, according to the last Gallup poll. And that's only people who felt comfortable marking that. And so I think that the population is probably a lot higher. We also have to remember that historically, queer people have been marginalized and pathologized by medical systems. And the concept of institutionalized heterosexuality, where there's this assumption that people are heterosexual, that is the norm and that is the default. And so, ways that genetic counselors can create a psychologically safe and inclusive environment for our patients during testing sessions, prenatal sessions, is using inclusive language. So, make sure that all your forms, questionnaires, and verbal communication include inclusive language. So, instead of defaulting to mother and father, you could use parent, partner, or co-parent. Just like Chelsea said, display inclusivity. So it's actually a little bit easier on Zoom to share your pronouns because you can just have it in your name. It's a little bit harder, I think, to look a patient in the eye and say, these are my pronouns. There's also, I think it's important to have those inclusive intake forms to display inclusivity by having visible signs of support in your office. But it's also important to avoid assumptions. You don't want to make assumptions about a patient's gender identity, orientation, or family structure based on appearance or other factors. Other ways that you can be helpful is by providing resources, having resources that are specific to LGBTQA plus health and family planning, including information on legal issues, support groups, and medical considerations. The last thing that I have to say, I told you I had a lot to say about this, but the last thing I have to say about this is regularly ask for feedback from your patients about their experience and how the practice can improve. And you don't have to just ask the queer people, you can have it as a normal part of your practice, but having questions that are inclusive to queer people on that would be, I would take that as a queer person, I would take that as a really, really good sign for the practice.
Yeah, sometimes it's tough that people will just throw up a rainbow flag or something. You're like, okay, that's nice, but are you really representing yourself that we're making the steps to be inclusive? Or are you checking off a box and putting a flag up on, the window at the front desk or something like that? And I think intake forms, that's one of the first things people experience when they're joining a practice or, rejoining. Sometimes the pregnancies, you may have a pregnancy 5 years ago, now you're coming back. And you hope that a lot has changed in 5 years in terms of that inclusivity. And what's so great about that too is it doesn't just positively impact the queer community and other members of our community, but also people that identify as straight and cis, because when we say partner, like we used to say husband, right? But a lot of people are not married to the person that they're having a child with. And some people don't have that person as their current partner. And so, different ways I think that we can be using inclusive terms that everybody benefits from, of like not making those assumptions, is so big, and asking. And I think for me, I have gone through our intake forms multiple times, and there were things that originally I was like, this is a little offensive because it was older. Like it just makes sense. Like it's going to not age well. So it's re-looking at these forms, and I think checking in with someone that is in the community, be like, hey, like, are these the proper terms? Or sometimes someone like, not to put you on the spot, Chelsea, but an advocate, an ally that really is familiar with proper terms and everything there. Are there things that you guys think of in terms of what we may be doing, maybe not intentionally, but to exclude patients without really realizing, or for people tuning in, that things maybe like red flags that are like, hey, this is not a great setup, and a better way to approach that? Anything come to mind for either of you?
Oh, go ahead, Chelsea.
Rosalia.
Okay, thank you. So I think that there can be an overemphasis on the nuclear family structure and overemphasis on biological parenthood. So focusing exclusively on the biological relationships and the traditional reproductive methods can exclude those who are using assisted reproduction technologies, surrogacy, adoption. Just like you said, Kira, having lack of training on these issues can lead to inadvertent insensitivity or ignorance. I hope that the genetic counseling community as a whole would like to avoid these microaggressions, and make their patients more comfortable. But not having training, you can very easily make not a mistake, but make someone slightly less comfortable than they would have been. I also think that if you fail to recognize the unique stressors and health disparities faced by LGBTQIA plus individuals, it can result in what appears to be less empathetic or supportive care. And not addressing or being aware of the legal challenges that patients may face regarding parental rights, adoption, or custody could be a significant oversight.
Mhm. And I was thinking a little bit more along the lines of like visual aids that people use in clinic, because I bet 90% of people tuning in still have a green book or Greenwood genetics book that they show chromosomes and show recessive inheritance. And so to combat that, one of the things the prenatal SIG did last year was we hired a graphic designer who's also a genetic counselor, who helped us redesign some inheritance pattern visual aids. And we incorporated some more neutral sorts of terms. So like sperm contributor, egg contributor. We have diverse representation visually on those visual aids. And so I think that's one thing that we have in our toolbox and we pull out all the time, like, oh, this is going to help. And maybe it is contributing to this overemphasis on the nuclear family, and just contributing to kind of like, oh, well, that doesn't look like me. And so I think there are lots of opportunities to evaluate not only your intake forms, but resources you're giving patients, and also what you use during a counseling session.
Yeah, that's huge. I mean, the visual aids, I think keeping those updated to reflect, what we're currently using in new terms, even like years from now, we'll look back at this webinar and be like, well, now this is a little bit different. And now we're changing language here. And I think that is just so important. And Rosalia, you mentioned some kind of alternative paths to parenthood there that queer couples may be more likely to pursue than straight couples, just kind of looking at statistically. And what are some of those, just to dive in a little bit deeper, for people that aren't as, fluent in what is available, so that people are aware, hey, there's these other options out there?
Sure. So there's actually a lot of options out there. Um, the first that I think a lot of people think about is adoption. So there can be domestic adoption, or international adoption. Some countries will not allow queer couples to adopt internationally, and some private adoption agencies have been sued, and I'm not entirely sure the result of that suit, but for not providing services for LGBTQ plus couples. An option for usually gay men or transgender individuals could be surrogacy. So you can have gestational surrogacy, which is an embryo created via IVF, implanted in a surrogate who has no genetic link to the child, or traditional surrogacy, where the surrogate uses her own egg. A lot of times for queer women, you would have sperm donation. And something that I think people don't think about when it comes to queer women in relationships with each other is reciprocal IVF. And what that means is one partner provides the egg with donor sperm, and that embryo is implanted in the other woman who carries the pregnancy, which allows both partners to be biologically involved. Because we know that what happens in the womb helps to shape a baby, even if they are not biologically related. Another thing that queer families find themselves doing a lot is co-parenting arrangements and blended families. So one or more partners, you've got to remember that not everyone starts out in a queer relationship, or there are bisexuals who are in queer relationships. And so one or both partners may already have children from previous relationships. And so blended families are also really important to remember.
Yeah, I think that's really important to highlight. And I think the one out of that list that most people are unfamiliar with is the reciprocal IVF. And I remember just learning about that and being like, wow, that could be a future for me of, dating someone that is of the same sex. I'm like, oh, maybe that's, how I'm going to become a biological parent someday. And then, you can do it both ways. I've had patients where a lesbian couple, they take turns. So they both have a biological child and they both were pregnant, but shared those roles, which I think is just such an awesome concept. So
Yep.
I think it's just so great to just learn about these different ways, and for people in the prenatal genetic space to be mentioning this to patients, especially in preconception appointments. I know that when we're talking about prenatal, we're not often focused on that aspect. And along with that, I think about with preconception, every prenatal genetic counselor, one of our soapboxes, I feel like Chelsea knows what I'm about to say, carrier screening, ideally before you're pregnant. And so I think with that, carrier screening is difficult in the sense that the way we've phrased it before is like, oh, the mom and dad both get screened. We see if they're a match for a condition, but we have to adapt this language. And I think carrier screening is just a great example of where those gendered terms come into play. Chelsea, do you have thoughts on just how we can approach this to be better in terms of that the biological parents involved, like a sperm donor or egg donor, may not even be socially involved in that child? What are terms that you've used just while you've been practicing?
Yeah, I think we run into this, and I think recessive inheritance is perhaps one of the hardest to switch out that language just because it's so ingrained in us, like mom and dad and carrier and all of this. So I actually do work for a screening company, and I talk about carrier screening all the time.
Yes,
Um,
you do. A billion to one. Yes.
I think the easiest way that I found to switch it out is we're screening for genetic conditions that have to be passed on from both parents. And so we have your carrier screening results here. Do you happen to know if your donor or sperm source had carrier screening prior to this? Or, if they have their own egg and a sperm donor, just putting it in the situation of these are genetic conditions. It's routine for us to screen for them. And we need both partners' information to have a really robust risk assessment. So I think that's been the easiest way that I've kind of switched that out, keeping in mind that with telehealth, appointments are often like shorter in length. And so I think that is also a challenge for counselors to think about, well, how can I be inclusive and also get to everything I want to and prioritize all of these things? And I think we mentioned it at the beginning. It's not just about making your counseling session and your language inclusive for the queer community. It's making it inclusive for everyone. And then once we sort of adopt those routines, then it won't take us as long or as much time to shift our language or shift how we set up a session.
And it's tough on the lab side too, and you have that experience now of setting it up so that it's straightforward and clear. Who I like those terms, egg source, sperm source. It's very scientific. Um, so with that, how do you see, you could say labs in general, or if you wanted to talk about the one you work for, of adapting this? Because oftentimes when I'm ordering from labs, it's okay, what is the sex of the person I'm submitting? And then they're not often asking for the gender. And then in the report, they use pronouns that are kind of going with the sex assigned at birth instead of maybe what that person's gender is, which, you know, we can also get into in general. But is there insight that you have in terms of how labs can make this clear but inclusive? Because I feel like doing both of those, that's hard to, you know, achieve.
I definitely can speak to this because it's something that has taken us a while at the lab I work at to make some of these changes. And I think when I was in the clinic and did not have laboratory experience, I was like, how hard can it be to
Mhm.
add a field on the form and on the results that's like assigned sex at birth? And part of it is a lot of logistical things. There are cap and CLIA requirements for how things are reported. So that does limit some of the things we're able to do. And additionally, there's a huge like billing sort of component that also relies on fields that are on the form. So all of that to say, it took us like 2 years to change the sex demographic factor that we report out to assign sex at birth. We don't report out gender on our form because we are really tuning into the assigned sex at birth for our risk assessment. But in terms of the rest of the report, we do stay away from pronouns that are gendered. And so it's like this patient has the C dot whatever, and is a carrier for sickle cell. The patient's reproductive partner is recommended to have carrier screening. And I will say probably the only reason why that is possible is because there are genetic counselors on the reporting side that advocate and make those changes happen. So if there is a larger lab, think of a very large lab, it's very likely that genetic counselors are far removed from that process, which can make changes very difficult. And so I think that also goes to show that we have to advocate not only for the patients we see, but for the medical community as a whole, and extending that to industry and laboratories as well. So I think there's so much work to be done and it's kind of overwhelming, but if you can start really small, it gives you a little bit of momentum.
And knowing that, as you said, it does take a while to get there. It can't happen in one meeting. You change all the forms. And like you said, there's so much red tape in terms of, well, how are things coded? If you do things a certain way as a lab, you may not get reimbursed by insurance companies. So there's all of this medical structure, you know, red tape, government stuff that gets in the way. And it's something we have to be patient with in order to get there. So I think, yeah, that's helpful to know as someone that I've been, you know, ordering stuff and I'm like, why don't they just change this? Right. And there's more that's involved in that. Rosalia, I feel like you have things to contribute in this.
So what I'd like to do is circle back to clinic because that's where most of my experience lies. And I like to think of things as a problem space and then an intervention. What can you do within that problem space? And so you've got this social difference with two parents with different biological relatedness. You're existing in this cultural moment where they might have had issues with the healthcare system. They've had to explain or even justify their family more than other families at times. And so an intervention could be, I'm taking a pedigree for both people. So I'm happy to do this for both people, regardless of biological relatedness. Walk through why this could be important or not necessary, recognizing the legitimacy of families, but acknowledging that there is emotional harm by the set of assumptions about family, and that medical care can be reshaped by that. I also want to warn that there could be potential for patronizing a patient with this approach. I'll take yours too if you want to feel special. Like, so you got to be really careful in how you approach it. Like saying, if you ever want to use a sperm or egg from your other partner, this is a service that I can give to you at this time so that you have the screening questions, you've been evaluated by a genetic counselor before you even start that path towards parenthood.
Yeah, I think that's so helpful. And we have a question. I'm jumping ahead a little bit because I just see a question coming in that's relevant to this. Someone asks, can we role play or give an example of taking a pedigree in a prenatal setting and using inclusive language? So I think even as you were saying, Rosalia, of going through and asking questions, and I've done this where I take both of the parents that are sitting across from me, taking their family history and a donor's family history, because I'm like, well, they're here. What if they have, a history of cancer where I should be referring them to the cancer genetic counselor down the street, right? It's like, if I have time, as Chelsea said earlier, we don't always have time to do all that. I'm a little spoiled. I have an hour with patients, so I can often get into all that. But are there certain ways that we should be approaching this, um, of using gender inclusive language while taking a family history? Are there certain terms that you use or ways that you phrase something?
I can definitely jump in there and kind of give
Yeah.
you 2 cents. I think it is helpful to contract before you take the family history. And I'm like a huge fan of just like pausing the session and be like, all right, here's what we're going to do. And setting up the family history, I think, can really give a lot of context because I think for a lot of things, especially in a healthcare setting, you're vulnerable, you're sharing information about your personal health, your personal history, and it's kind of like, well, do you need it? And so I think when setting up a family history, you can just say, we are getting a picture of your health and what contributes to that. I'm happy to take both of your guys' health histories. I'm going to be asking about people that are related to you. And it's simply to gather information, make sure we don't need to take care of you or the pregnancy any differently. And I think that's just say, I'm going to ask about relationships. You can say biological relationships. And then I think when we're talking about like denoting on a pedigree, there's obviously pedigree standards, but I think also explaining to patients like people with 2X chromosomes, I represent with a circle, a person with X and Y chromosome, I represent with a square. If you prefer something else, like please let me know, but this is just so I can go back to my notes and know what we chatted about. And so I think even giving that explanation, it's way more than you get from like any provider that's walking in. They don't tell you why they're doing what they're doing or why they're asking what they're asking. And I think that is basis for an inclusive environment for everybody.
Yeah, I think that's really good to be able to provide that overview because how many times have we just been patients? And you're like, why are they asking me this? Or when you're filling out a form, you're like, why do they need to know this? And oftentimes they don't, which is frustrating. But I want to say, and we're biased because we're genetic counselors, but if we're asking a question, there's a reason for that, right? Like we've all been asked, why are you asking me if I have Jewish ancestry, right? And then we go into our explanation, right? So sometimes we'll preface it, hey, I'm asking this because. And I think that's really great and part of the rapport building throughout the session. I know for myself, when I'm asking about, oh, do you have a partner? I used to assume, I used to say, what's your partner's name? And I'm like, no, that's an assumption. I got to get rid of doing that. And I will ask, oh, like, what's their name until I hear them say a pronoun. So I think that's something that for me, I feel a little awkward about asking, what are their pronouns? So I just wait to hear it and then I'll start using that pronoun. So that's one of the ways that I do it to just have it feel a little bit more natural in the conversation. And for myself, I also ask, oh, do you have any siblings? If I'm talking about, if I'm specifically asking, which I don't often do, but about aunts and uncles, maybe because someone had cancer in the family and I'm like, all right, let me see if there's more cancer there or something like that. And I say, oh, does this parent have any siblings? So really just using a lot of that. Oh, does this sibling have any children? And for me, I don't often ask about their sex unless it's relevant. So if like Fragile X or something X-linked comes up, then I want to go back and be like, oh, what sex were they assigned at birth? But oftentimes I'm not asking for the sex because I'm trying to move along. I don't care, like, in a good way. It's not relevant, so I'm not going there. So I think that can be helpful too. I think I get into sometimes still figuring out my wording with asking about their parents. If they starting ask about one parent, it's kind of hard to transition to the other parent without asking. So if Chelsea, you were my patient and I'm like, "Oh, okay, like, are both of your parents living? Great. Do they have any health issues?" And you start talking about your dad, and then I'm like, "Okay, well, how about your mom?" And I still kind of go there where I really should say, "How about your other biological parent?" But it's getting into the rhythm, right? So it's like nobody's going to be doing a perfect job with that. But I think part of all this is being able to be advocates. And that's what we're both, all three of us are doing today. And, you guys spending your time doing this. I think it's important in this advocacy space to identify specific structural and cultural barriers that LGBTQIA plus individuals face when seeking reproductive and family building care. Rosalia, do you think of anything in terms of like these barriers that we can, identify and share with the audience, maybe things that we haven't mentioned before?
Yeah, so I think there are multiple areas where things can get sticky, right? And I think that one of the most important things to remember is that we are trained in being counselors. And so if we mess up, which all of us are going to mess up, we should be able to repair that rapport and do the best that we can to repair that rapport, and not to be sort of thrown off by it for the entire session. I think that's important because when I did my research for disclosure behaviors in genetic counseling, a lot of the genetic counselors endorsed feeling nervous or concerned that they would say the wrong thing or concerned that it would throw off the whole session if they said the wrong thing. And I don't think it has to. I think that we can forgive ourselves in the moment and move on. And I also just want to point out really, really quickly that people in queer relationships or in the queer space may not have a good relationship with the rest of their family. And so asking about family can be a little touchy in that scenario. And so just making it clear that you are asking for medical reasons, and explaining why. I do a lot of contracting before I take a pedigree. I say, oh, this is what I'm doing. This is why I'm doing it. And I think the contracting beforehand and making it clear why you're asking these questions can be really helpful for patients who are um, struggling with relationships within their biological family.
And prefacing, you may not have this information about family members. A lot of people only know certain things, like, so that they don't feel ostracized of like, well, I don't have a relationship with that individual. I don't know. I only knew them up till this age or something. Or like people that unfortunately, because of coming out, have lost contact with most of their family. So there are things to be aware of. And I even say that for people that know their family, because I'm like, if they're like, oh, I don't remember the diagnosis, it's okay. Most people don't remember everything, or even if they have that relationship. Chelsea, do you have something to add on to that?
I was just gonna say that I think taking pedigrees, there's a huge emphasis on that, like in graduate school for obvious reasons. But I also don't think that that is the end all be all, especially in a prenatal setting. Certainly more emphasis and important in like a cancer family history or assessing for risk there. But I also think that sometimes we may hang on to certain pedigree aspects just because that's how we were taught, and it was, this is really important, you have to ask these questions, you need a 3 generation pedigree filled out to the max with all of the sexes of your nieces and nephews. I think we can challenge ourselves to ask, why do I ask that question and do I need it for this setting? And what you need for a pedigree and prenatal may be different than cancer. And so I think maybe just having some time for self-reflection and really honing in on why you are asking what you're asking. I think that's a good practice to engage in no matter what, but I think it's particularly helpful here, especially if the pedigree taking part of the session is where you might feel nervous as a genetic counselor. If that's where your anxiety is lying in the session, evaluate why that is and what questions you may encounter and which questions are imperative and which ones are not.
And being able to adapt if you see a patient is becoming visibly upset, or they're getting frustrated because they just don't know the answers to all these different individuals' health, because oftentimes we're going family member by family member and then asking overarching questions. Maybe just switch to that. Be like, why don't, and you don't even have to tell them that you're doing things differently. There are so many times in a session where I'm like, okay, this isn't going well. Let me switch gears. They don't need to know that I normally don't do that. They don't know, right? And going to have some questions now, just thinking about anyone in your family, extending out to, like, I usually say first cousins and, your parents' siblings and grandparents. So again, try and use that neutral terminology and asking those overarching questions, because they're like, oh, I do know someone in the family experienced early menopause, say in their 30s or something. Then we can denote that, instead of me going individual by individual and then being like, I don't know, I don't know, I don't know, right? That's also not productive. So I think looking at that and being able to be adaptable in these settings. And it's important for us as genetic counselors and healthcare providers in this prenatal genetic space to support access to equitable care and reproductive options. Is there anything that come to mind for you guys in terms of having recommendations of how to be involved or how to find these resources for our patients that are in the community?
I have a few, but I feel like Rosalia will actually have better recommendations. So I would love to hear from you.
Yeah, so there's a lot of things you can do, right? So you can seek out education. You can read. There was a Pride edition of the NSGC, the Journal of Genetic Counseling, and you can go through and read all of the queer studies. And I
And that's
actually,
open. Anybody can read
yep,
that right now. Yep.
I really, really recommend that because there's a lot of very interesting research that's happened in the last couple of years. There's something called Safe Zone. So I'm not endorsing this. I have no personal connection to it, but Safe Zone training is something that you can just Google and get a Safe Zone training. My hospital is very friendly in that they offer Safe Zone training to all of their employees. Um, you can also, there are some podcasts and podcast episodes about LGBTQ plus people and their struggles and their, queer joy. I think other ways that you can help is really reading the Bennett paper on pedigrees that was just updated, because I think that I don't usually, so I work a lot in telehealth for the initial consultation, and then I see patients in person for the return of results. And so patients can't see the pedigree that I'm drawing. But for individuals who do draw the pedigree in person in session and explain what they're doing with the pedigree, drawing people in the way that their gender identity is, and then writing AMAB or AFAB underneath, I think it's the new standard and it could be really, really helpful. So AMAB stands for assigned male at birth and AFAB stands for assigned female at birth. And so if you have a trans man, you can draw a square and make them feel affirmed in that squaredom, and underneath write AFAB. And they'll understand that because AFAB and AMAB are really common terms within the queer community. And so just being like, just so that I remember for accuracy, this is why I want this information. I am going to write AFAB underneath your square. But like, what is important is your gender identity.
And that is just so affirming to
Mm-hmm.
have someone sitting across from you be like, I see you as a man, and I am acknowledging that and affirming it. And I think that's just, there's something so powerful in that. And I want to circle back to what you said about Journal of Genetic Counseling. So I do have a tie here. So I'm one of the producers on the brand new podcast for the Journal of Genetic Counseling, DNA Dialogues. And for people watching this live, tomorrow, or sorry, we release the Pride episode at the end of May, just so that it would be available all month. We have a new episode coming out tomorrow, but different topic. But so just so important to be, highlighting this, and that things are open access right now for that, and a lot of good resources there. And for people watching live, you can go back to phenotips.com, and then we're going to be posting this recording, and we're going to have links to things that we've mentioned throughout. Chelsea, what do you have to add on?
Sorry, I was like raising my hand, and I just wanted to add that, Rosalia, I'm so glad you brought up like reading and educating, because I think for those of us that went through graduate school a long time ago, but maybe a while ago, how this is taught and the emphasis that is put on it is very different. And so I do have to go back and re-educate myself. And so I think recognizing when there are gaps in what you know and what you've done for historically, and remedying that, so actually taking steps to do it. I found a couple of articles that were not in Journal of Genetic Counseling, but those are all excellent. Amplify Sprouted, Amplify, those are all amazing training, and they've been shown to increase genetic counselors' confidence and comfort with addressing queer community needs. But I also found just some studies about healthcare education in general, about patient simulation. So most of us have patient simulations in graduate school to practice like on a fake person that's real. And I saw a couple of studies where this was implemented, and they had a community of queer individuals that volunteered to be these patients, and were a part of that sort of curriculum, and you could practice. I thought that was like genius. And I'm like ready to email my program director and be like, why haven't we thought of that? Not how easy is that, but like how impactful is that? And I think there's also just a lot of ideas out there about how do we include and learn from the queer community, and sort of this cycle of learning. And I did just want to mention that if we had a community or like a bank of people that felt comfortable talking about their experience as a queer person, recognizing that all of it is different, every person is different, their experience is different, all of those things. I think that has shown to be a very effective way of people learning and being more comfortable. That being said, I think there should also be funding and compensation for people as they share their experience. I think that is something that is unfortunately overlooked. And a lot of people are like, well, just share your experience. But I think to really value and to affirm somebody's lived experience and what they're bringing to the table as we are learning about this as a community and as individuals, I think compensating individuals for their expertise and their experience is something that should be considered, and something that NHTC could really think about as well, having like a speaker fund. So I just wanted to throw that out there as other potential things to consider.
Yes, I love that you brought up Amplify Sprouted, because I was one of the genetic counselors that was in the original, like, I guess, pilot project of it. And I got to do it. I got to do a role play with someone that's trans, and we really hit it off. And that person ended up being a panelist on a PhenoTips Speaker Series, Pride, a few years ago. I want to say 2 years ago. His name's Holden, and he's just amazing. I still think about how much I've learned from Holden, and yeah, definitely people should go back and re-watch or watch for the first time those other Pride installments we've done. But Amplify Sprouted is amazing. If I'm remembering her name right, Gabrielle is the one that started that, and I actually interviewed her too, just about her experience of developing this. So yeah, so many good resources, my goodness. And I see a lot of questions kind of popping into our Q&A box. So everybody feel free to add your own questions in. I do have one question of my own before I get to that, because I cannot have this webinar end without asking this, because we've experienced as prenatal genetic counselors I want to do the gender test. I want to do the gender test. And this is a difficult topic, I think, because that gender test, and I'm putting that in quotes for people listening to the audio version of this, that people mean the non-invasive prenatal screening that's looking for the presence of the Y chromosome and coming back with the predicted sex of the baby at birth. And so that's the way that I would phrase that. But how can genetic counselors and other prenatal genetic healthcare providers approach these conversations about the sex of the baby, especially when the patient is starting that conversation by saying, I want to do the gender blood test? Rosalia, do you have thoughts in terms of approaching this not to be patronizing to our patients, but also maybe kind of correcting or using, I want to say proper terminology, because this is still something that I'm dancing with. And I'm still trying to figure out how I can accomplish both.
Yeah, so the genetic counselor role is a very tricky one because you need to provide information and you need to think about what is useful to convey in the moment. So I think it's important during the first session where you're doing the contracting and you're explaining about the testing is that, yes, this can tell you about XX versus XY, but it can't tell you what the future will be like. And I think a lot of people coming in and saying they want the gender test, you got to say these tests are powerful enough to return wildly other things, right? Like we thought we would learn about sex and we learned about disability. Um, and there is just overdetermination of sex and gender, right? The counselor doesn't need to be conflating sex and gender. What we know about sex chromosomes is actually not that much, but it often corresponds with gender identity, but it's not always. And if you frame it in the language of accuracy, queer people are looking for flags of confidence, and not over-determining sex can help with that.
Yeah, I think looking at that is valuable to use terminology that is appropriate. Like some of the ways that I've approached this is saying, so this is what some of what we can learn from this test, including, the other aneuploidies and microdeletions and all that, and that, kind of breaking it down a little bit and being like, we're looking for the presence of Y because that's really, what we're picking up on with NIPS. So I think it is challenging. I think it is in terms of rapport building and honoring. It's like learning the predicted sex of someone's baby. I haven't been pregnant yet. I hope to in the future, but that must be something that is, wow, it's another milestone in the pregnancy. I'm now like closer to that and imagining what that's going to be like. And as the prenatal genetic counselor, I don't want to take away from that.
Mhm.
But it's for me of I never say gender. I always do say sex. Even if they keep saying gender, I'm sticking with saying sex, but not, I don't know. I don't say, well, it's the sex. I kind of just say, this is what we're looking at and using that term because I don't want to like correct them necessarily and also damage our rapport. So it's, I don't know. Chelsea, what do you think?
Yeah, I mean, I was prepared for this question, but I feel like it is something that is patient specific, but also it's just hard to know what the right way to do that is. But I often ask myself, why is this exciting to them? Like why do they want to know this over chance to have like a disability or trisomy 18? And I think it boils down to it is a big moment. It's a celebration. They are excited. And so I don't want to like bring the mood down, but I do think it is our responsibility to be like, I'm so glad you're excited to get to know your baby a little bit better. Our test gave us a lot of information, but we know that this doesn't tell us everything about your baby. And I'm so excited for you guys to see who they grow up to be. I mean, that's my prenatal counseling voice in case you couldn't hear.
I love
But
it.
yeah, I think like sharing the excitement and naming the excitement can help decrease sort of the emphasis on NIPS predicted you're having a female or a male. And that's actually how I do describe results. I say test is predicting female. You'll see that on your report. Of course, you're still going to want to have your ultrasound and all of those things. So I think in a way that's a roundabout way, and I don't know if there is a better way, but I think that's a gentle way to share the excitement, maybe correct some of the mislabeling and misinformation, and then also kind of give them a heads up like, hey, there's going to be other checkpoints in the pregnancy, and once baby gets here, they're going to do their own thing. So I think just sharing in all of those different things as you're giving this news is it's hard, it's a balance, but I think it's doable.
Yeah, I think that's a really great way to approach that. And I want to get to, we've answered some questions as we've gone along from the live audience. One that I want to get to is, have you ever had to explain the difference between trans and intersex, or differences of sexual development? If so, how do you approach this of kind of talking about how there can be differences, that it's not, sex is not binary, like there's been a big emphasis on in our culture. Any thoughts on that from either of you?
I will say it does come up, not necessarily that specific example, but there can be ambiguous genitalia on an ultrasound or discordant sex on ultrasound versus the NIPS result, and we start to have these conversations. But I actually encounter questions about gender identity and gender expression and sexual orientation more so when we're talking about sex chromosome differences.
Yes.
So like XXY, XYY. I often have patients misunderstand the role of sex chromosomes and gender expression and gender identity and sexual orientation. And so in that way, I do feel like it's appropriate to educate the patient in that moment. That's a different situation than being like, oh, we're predicting male or female. It is, sex chromosomes don't tell us anything about a person's gender expression, gender identity, or sexual orientation. It's going to be like many things in parenthood. You will find out, your baby will tell you, and it's your, your job as a parent to listen and figure out what they need, and you'll be able to do it. Like, that's what being a parent is. And so I think it is important in those situations when somebody does ask a direct question or possibly has misinformation, to address it and just really explain kind of the difference between those things.
Yeah, it definitely comes up a lot with, I found, when I'm explaining Turner syndrome or Klinefelter, or, I'm learning even with Klinefelter, people in the community would rather refer to that as XXY syndrome. And so, things that we're learning with that is a common question I get. I'm like, oh, well, a patient will ask, well, does this mean they're going to be gay? And kind of breaking that down, just like Chelsea, as you explained, I think is really helpful. I think we have time for one more question. So the question I wanted to get to was, I'm realizing it just disappeared. Sorry, guys. One thing that, I've experienced and I think is important to talk about a little bit. Rosalia, I know you kind of mentioned it, that you answered this person in the Q&A box, but I wanted to just allow that to be recorded as well. The question is, do you have any advice on responding to patients, maybe older generations, who have become offended or angry when they're asked for their pronouns, or when you're doing other things that are inclusive in nature, but people respond that way? I don't know if you wanted to kind of sum up the thoughts that you shared in the chat there.
Yeah, so there's actually been research into this, and forgive my voice and my
Yeah,
coughing.
sorry. I realized you were coughing, so I was trying to delay a little bit.
I have COVID right now.
Oh, I'm so sorry.
It's okay. It's okay. I'm at the tail end. But there actually was a study called a study by Rulo et al. In 2018 that did look at how older generations in the Midwest felt about being asked about pronouns or having pronouns on an intake form. And that study found that collecting information about sexual orientation and gender identity is generally not distressing to patients. I think the benefits of routine collection in sexual orientation and gender identity from all patients, and normalizing the collection as irrespective of the patient's apparent LGBTQ+ study or chief complaint, is more important than for more people. Because remember, 7.1% of the population, that's more than most of the diseases we see, right?
Yeah.
And again, those are only the people who responded to the poll. Um, so I think the benefits does outweigh the risk of someone getting offended or someone being upset. That being said, I think the way that I would approach it is I would say, sometimes it's really difficult to be asked questions like that. And, it asks something that you might not want to share with me, and that's okay. Like, you don't have to fill out that part of the form, you don't have to answer it. And you can tell me that you are cishet and whatever language that you want to tell me, and we'll move on because that's not the most important part of the session for you specifically, even if it might be an important aspect of the session for trans or LGBTQ plus in general persons.
I really love that. I'm gonna have to go back and watch this webinar, honestly, because I'm not taking notes because I'm hosting. Of just you guys shared so much helpful information and phrases and terminology to use that's just so incredibly helpful as we are all learning and that we're all gonna make mistakes. And it's just identifying that in the moment and promptly moving on. And I think there's just so much more to learn. I wish we had another hour, honestly. But as you guys see, time is up. So you'll see a feedback link in your browser when this webinar ends, as well as emailed to you in the next day in case you are popping to the next patient, like I know Rosalia is. So we'd really, really appreciate if you guys can take a minute to offer feedback, and it helps us improve our future installments and also the topics that we cover. So that email will also include a link to the PhenoTips Speaker Series page where you can sign up to receive alerts on all upcoming sessions. If you want to go directly there, you can go to phenotips.com, click the resources tab. The speaker series is going to pop up on that drop down menu, and all of our installments are on there, all 28, because this obviously needs to be produced. It will not be on there immediately. But stay tuned for our next webinar. It's going to be coming this fall. Chelsea and Rosalia, thank you so much. This was just so great. I love celebrating Pride on the PhenoTips Speaker Series, and especially being able to talk about my specialty was just very special to me. Sorry, dad joke. Sorry. But thank you both so much. And everybody, thank you for tuning in. Happy Pride Month to everybody, and stay tuned for our next webinar. Bye, guys. Bye, everybody.